Hi, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, with highlights of a recent webinar in cardio-oncology. Today's highlights are presented by Dr. David Austin of the James Cook University Hospital in the United Kingdom. Dr. Austin is the lead investigator of the PROACT trial. The trial focuses on cardioprotection in patients undergoing treatment for breast cancer and lymphoma. He provides great insight into the actual execution of the trial. We will present 2 edited excerpts today. And while you're at it, please don't forget to check out the ICOS website for all things related to cardio-oncology. And now, please enjoy Dr. Austin's presentation.
So what are the key design features of PROACT? So it's a multi-center randomized controlled trial. We used a probe design, so this is not placebo-controlled, this is open label, but we took great care to blind the endpoint analyses at 3 separate core laboratories, 2 for troponin and 1 for echocardiography. We went down the route of enriching the population, and again, looking at the data at the time, a lot of the kind of historic data on dose is obviously really important, and I appreciate that doses have come right down in standard practice, but there are still a cohort of patients receiving greater than 300 milligrams per meter squared doxorubicin equivalents within the breast cancer group at the time, and there's obviously other groups as well, such as the sarcoma and lymphoma groups. So these patients do exist, albeit lower than the historic sort of high dose anthracycline from the sort of 70s and 80s. We wanted this to be a fair test of enalapril, so we wanted to make sure that the enalapril was titrated up to 20 milligrams daily. And our endpoints, in the end, we went for the biomarker endpoint being the most sensitive, so that our study was going to be, we could be sure that our study was going to be well powered. But ultimately, and we didn't know this at the time, what we looked at within our trial was ultimately enshrined in the ESC Cardio-Oncology guideline in 2022. So I was kind of happy to see what they plumped for in the guideline, because it kind of aligned fairly well with the PROACT trial as we designed it back in 2016. Okay, so what are the aims? The aims were to establish the effectiveness of ACE inhibitor enalapril in the prevention of anthracycline toxicity in patients with breast cancer, and ultimately, and I'll come on to some of the challenges, non-Hodgkin lymphoma. We aim to compare cardiac troponin T release in patients with breast cancer and non-Hodgkin lymphoma compared with in patients receiving enalapril versus those receiving standard of care. And the null hypothesis was that there was no difference in cardiotoxicity between the 2 groups. So what are the key findings of PROACT? So 81% of patients had a myocardial injury based on troponin T criteria. 46% of patients had myocardial injury based on troponin I criteria. And we can see as a sort of secondary finding in this study that troponin T and troponin I did not give equivalent results. Just over one-fifth of patients had a reduction in GLS, and 4% of patients had a significant reduction of left ventricular ejection fraction at what is a relatively early time point after chemotherapy. But we can conclude that enalapril did not affect the myocardial injury or cardiac function.
I hope you enjoyed this very useful presentation. The information is helpful and the insight fascinating. It's not too early to make plans to attend the GCOS Summit later this year in South Africa. On behalf of ICOS, we remind you to treat cancer, protect hearts.